Welcome to fabulous Las Vegas, but more importantly, welcome to the 28th Cervical Spine Research Society Instructional Course Lecture. My name is Michael. My name is Jason Savage from the Cleveland Clinic, and I have the pleasure of co-chairing this session with Max Mayoki from University of Louisville. So without further ado, we're going to kick things off. I'm going to introduce Andy Heck and Brad Segabarth, who are going to moderate the first session.
Thanks, Jason. We have a couple of short talks, and then we'll go into a case debate. So the first presentation is on new imaging modalities for cervical spondylitic myelopathy by Dr. Ghogawala.
Thanks so much for having me. I wanted to, at the outset, recognize Marjorie Wong, Matthew Buddy, and Aditya Vendatam, who helped me put this together. So I'm sort of subbing in for this particular talk on new imaging modalities for CSM, and I'll go through that with you. In terms of disclosures for myself, I have some federal funding related to some of the data that I'll show to you, and we've been doing some cost analysis separate from that. But I'd like to really acknowledge the group at Medical College of Wisconsin, which has done a lot to develop our understanding of how to use new approaches to diffusion imaging on MRI to evaluate patients with cervical spondylotic myelopathy, and you see them listed here. So we know the problem. The overall background here is that we treat patients with cervical myelopathy, the largest cause of spinal cord dysfunction in the world, with surgery. Our approaches are largely successful, but with a relatively high complication rate, depending upon which prospective studies you look at, 15 to 18%. A lot of cost involved here. In the United States, we do about 40,000 operations for cervical spondylotic myelopathy per year. And while the majority of patients improve, we all know that there's a large number, a relatively large number, 15 to 20% of patients who just don't improve after first surgery for cervical spondylotic myelopathy. And we don't have a lot of good ways of understanding that. And so that's what this talk is all about. So I just show you here a classical case, a gentleman in his 50s with mild symptoms of cervical myelopathy, some tingling in his hands, had zingers in the dentist's office when he was leaning back, and had myelopathy on exam. And you see here on his MRI, he has 2 levels of stenosis at C4, C5, and C5, C6. And he underwent an ACD and F at the C4, C5, and C5, C6 levels. Questions that we have are, is this the best operation? Is the patient going to improve? Perhaps more importantly, and does anybody really know? And that's what this talk is really about. From my perspective, we recently completed a randomized study looking at anterior versus posterior surgery for cervical myelopathy, and published those results. I show you here just one image of the data, which illustrates for each patient. There were 163 patients randomized into this study. For each patient, you see a bar whether they went up or they went down. And so the focus here is to recognize that of the 163 patients that were in the study, 20% of them either were the same or got worse, whether they had anterior surgery or posterior surgery. And that's really the subject for our thinking this morning. If you look at the pathophysiology for cervical spondylotic myelopathy, there are a number of factors to consider. There's structural issues, spondylosis, stenosis, OPLL, and so forth, that we have good ways of assessing and measuring. We have dynamic factors, flexion and extension radiographs are helpful for that, but there are also vascular factors and biomolecular factors that we don't have a good way today of understanding and measuring, and that's part of our problem in terms of predicting outcomes from this disease. We often look at MR images after there's been a traumatic injury or in patients with degenerative cervical myelopathy and see edema in the spinal cord. But this also is, while it's indicative often of axonal injury, is not always predictive of axonal injury. And also there are dynamic aspects to this, and you see here illustrated on this slide, depending on the number of hours post-injury that you image a patient with MR imaging, there's a different pattern of their edema. So diffusion tensor imaging, which has been largely developed at the Medical College of Wisconsin, but in many other sites as well, aims to take a look at the diffusion of water molecules and understanding that an intact cellular membrane restricts that motion. And you see here on this fractional anisotropy image that you can clearly see the white matter tracks in these MR images. And that's been now applied to the spinal cord to understand what is the level of injury in the axons that might help us predict who's going to get better and who won't get better. And here I show you here that there are good, relatively good data suggesting that when there's axonal sparing in patients who have cervical myelopathy or spinal cord injury, this is associated with specific changes on the diffusion tensor imaging as measured by the FA. And in chronic injuries, you can often see the damage on patient spinal cords, but in the acute setting, especially a few hours after injury, it's harder to see, and these DTI techniques improve our ability to do that. I show you here how DTI has been used to look at proximal spinal cord parenchyma to identify diffusion abnormalities at C1 and C2 when an injury has occurred lower, just to give you an understanding of how axonal disruption or axonal injury can be assessed with these diffusion tensor imaging techniques. This has also been shown to correlate with outcome 3 months and 12 months after surgery. And I'll show you here how the modified JOA scores go down with elevated FA scores. And you see here also at 1 year. But you'll notice that there's a lot of scatter with these images, and there's, in a sense, some discordance between the overall DTI and functional outcome. And this is largely related to edema in the spinal cord, which complicates our ability to do these diffusion tensor imaging. And so therefore, there has been interest in trying to reduce some of the impact of edema so that we can better understand axonal injury using these MR techniques. And I show you here just one other problem with diffusion tensor imaging, which is that you can't measure easily those FAs when there's spinal instrumentation, so you can't measure them after surgery, and this has been a limitation of that technology. Perfusion MR has emerged as one possibility, but this has sort of an on-off phenomenon. Either there's a perfusion deficit, which is indicative of a more substantial injury or not, more useful in trauma as opposed to degenerative cervical myelopathy cases. And then there's a couple of new techniques that I'll just share with you. Double diffusion MR imaging, which is less sensitive to edema and therefore more likely to identify axonal injury and loss. And I'll show you just a couple of examples here. If you take a look here at 48 hours in the composite, you see these double diffusion imaging showing red for injury, which correlates very well with what you see 30 days later on MR on T2 weighted imaging. So an early indicator of significant axonal injury versus mild injury. And if you look at these chronic compression data in a rat model, you also see here on day 2 the red indicating the axonal injury, which is not evident initially on MR imaging. And this can be quantified with these ADC measurements, which can be then useful for studies. And one last point is now an advance further on this double diffusion technique, which is a filtered diffusion weighted imaging technique where they block some of the signals associated with edema to get a clearer signal with these types of images. And these are just now being studied by the group at the Medical College of Wisconsin, looking at their ability to prognosticate patients who have cervical degenerative myelopathy. So just to sum up here, preliminary data on diffusion sequence imaging. Diffusion tensor imaging has some limited clinical applications, primarily because it is confounded by the edema in the spinal cord. Perfusion MRI is useful in significant spinal cord injury, but probably not as useful for us in understanding degenerative cervical myelopathy. double diffusion MRI, as well as filtered diffusion weighted MRI more promising for CSM because they can evaluate axonal injury without being affected as much by the edema in the spinal cord on these images. Further studies are clearly needed, and we look forward to seeing more outcomes data with these advanced diffusion imaging techniques. Thanks so much.